So, Paul, I think we were going to start off and talk about a little bit about what our systems have been doing from an AI perspective. So, we want to give some examples on what Maine's doing and what's worked and what hasn't.
Sure. We've actually done quite a bit of AI work in the business office. For example, we have automated our cash posting where we're actually using AI bots to actually process 835s, reconcile, and it does about 92% of the work. We're using it in pre-authorization with the insurance companies. We're also using it to do indexing of scanning. So when someone comes to our hospital with medical records from away, we actually scan them and we have AI technology actually putting them in the chart in the right place. That's some of the projects we've done. We've also done some things with the state during COVID-19 using AI technology. So that's a few of the things we've done.
Very cool. And on the back end, I can imagine some of those efficiencies really have some great ROI with them. So that's great. When we look at AI from a digital health innovation perspective, there's a few areas of focus. It's how do you engage patients with AI? So it could be programmatically, it could be through health coaching, or one of the many wonderful digital therapeutics that are out there. It's also workflow based. So how can we get some of those efficiencies? How can we decrease the burden on our providers for some of these repetitive tasks and make them perform top of license? And then to Paul's point on the back end, how do we streamline all this and make it so that the administrative burden can be relieved as well? So it really spans the gamut, and we've seen some promising solutions in probably all of those phases of the work. But as folks have mentioned, it's still very early. So a lot of it's pulling behind the curtain and seeing, is this really AI or is this just a really fancy algorithm? And Paul, I know you've hit that a few times on your end.
Yeah, as far as I'm concerned, a lot of the work we've done have been really fancy algorithms that we add to with really talented programmers and engineers that are able to move quickly when something changes. We're starting to play with predictive analytics as well, but I don't think we have deep adoption of artificial intelligence at this point. I haven't really heard anyone that has, and I'd love someone to share with me some real deep adoption. I'd love to hear that.
Anyone in the crew have a good story around AI really working and it being legitimate AI or promising AI?
Jake here from Boston Children's. So I'm actually on a team right now that's kind of thinking through an enterprise AI strategy really for the entire institution and kind of trying to think through the steps here. And I think, Paul, a lot of what you said really resonated with what we're seeing. Before I had even joined the, kind of the AI, the enterprise-wide hospital AI effort, there was already ongoing efforts in prior auth within our finance department. Kind of really the shining star use case or example. But I think we are seeing similarly, we're really just trying to target very specific individual use cases with ROI in the short term, while thinking through broader infrastructure requirements in the long term to be able to really scale these things at the level. And yeah, it's part of my efforts to talk to a lot of hospitals in the space, and I think all very much in the same space of really trying to figure out some initial use cases.
Yeah, and I don't know, Jake, if you're doing the same thing, we've really focused on the low-hanging fruit, meaning, first of all, you have to have a process that can repeat itself, and you have to lean that out. But we're looking at projects with 3 to 5 times ROI. So if we're going to take something on, right now, we got a 5-time ROI on our cash posting. So that was one of the big wins. When we took on prior auth, we think we got about a 3-to-1, or we'll get a 3-to-1 when we're finished. So are you guys looking at things that way as well, Jake?
Yeah, absolutely. We're actually in the phase right now of building out ROI or business cases for very targeted specific use cases that we've identified within the hospital. I think we're going to be targeting very similar low-hanging fruit use cases, really kind of no-brainer operational wins that just so happen to be able to be addressed by some AI technologies.
So if I'm hearing you both correctly, what you're basically saying is the place to have impact where you have repeatable processes tend to be in administration and finance?
I think it's the place people are willing to try it. Okay, I think it has the ability to play in the clinical space as well, but I don't think that folks are willing to try it there yet.
And is that mostly because outcomes are harder to measure, so people don't know what the ROI is?
I think it's that. I think it's, when Tesla has a car that drives itself and it gets in an accident, it's broadcast on every news station, but how many human beings get in an accident every day or every hour and you don't even hear about those? So I think it's just because it will be such, all the eyes will be on it if it's playing in the clinical space. Where if it's playing in my business office and it messes up cash posting and posts money to the wrong account, well, that's something that we can fix and no one knows about it. I think that's my opinion on it. I've talked to a lot of clinicians, and actually I led up a piece of the COVID-19 vaccine clinic for our organization. We basically created in 2 days scheduling and online registration, things of that nature. And everyone was excited to do it in that space because we were building the plane while we were flying it. But if it was something, we can always fall back on, well, we did this in 2 days, what do you expect? So I think it comes into some of that though.
Interesting.
I don't know.
Well, that resonates with myself as well, because COVID did have emergent needs that we had to react to quickly, and we looked at technology to meet some of those needs. And so recently we were faced with a dilemma. We have around 600,000 patients that only have a landline in our file, but we still want to make sure that we're doing our best to outreach to them to get them a vaccine and get them scheduled in for the vaccine. So a lot of our digital outreach campaigns, we didn't have the information. We didn't have a mobile number to text them. We didn't have an email address on file to email them. So we actually turned to AI to see if we could help handle some of this bulk outreach and tie that to scheduling back in directly to our vaccine clinics. And while, I'd say our conversion rate wasn't as high as we had hoped, the AI was able to get through 600,000 patients in about 2 weeks. We were able to make an earnest effort and, at least give people the opportunity. So, and to your point, we were always able to fall back on, well, the results weren't that great, but we learned a lot and we were able to do it quickly. So that was a win.
Yeah. And I think you're giving a certain amount of grace in those emergent situations. I think we had a tremendous amount of success during COVID-19 using AI technology.
That paved the way. I see Orion joined us too, and I know he just had a wonderful presentation on how AI is helping with image diagnostics. So that's certainly from a clinical side, some of the spaces that we are seeing AI really come into play and be really effective. So Orion, I don't mean to put you on the spot, but would love to get some of your thoughts on how you're leveraging AI to further your startup.
Yeah, so for our, core tenet on AI is it is something that is supposed to help a clinician or a provider. It is not something that is going to replace them or in any way supplant them. Humans and AI have very different ways of working and can catch each other's mistakes. So if you make a tool that is something which we're trying to do right now, providing additional information and making it very clear to local providers or even specialists the types of information, specifically for our case, for burns, the type of information that you use to make diagnostic decisions and putting that in the context of what other cases outcomes have been, what the sort of standard guidelines are, and potential additional risk factors that might be specific to a population of patients. That is an example of AI working hand in hand with providers, which we're hoping is reducing the level of discomfort that someone might have with putting their health into the hands of a robot that, as Paul brought up, could crash and burn, and you don't want to be the person in a self-driving car that crashes. So making sure there's always that human element, and that AI is just there to augment and make some providers' reach go farther. That's really the core tenet of what we're trying to do.
It's exciting as clinicians get more comfortable with this type of technology. Hopefully, it's becomes the norm and not an outlier. So, do other folks have questions around AI, just in general with getting into the hospital system? We have a few other general topics we can cover, but want to make sure folks have an opportunity for questions.
Hi, I have a quick question. So first of all, I'd like to introduce myself first. I'm the assistant professor from College of Engineering at Northeastern. I'm teaching the healthcare system modeling and analysis, and also teach data mining and engineering. And I also involved in several projects with the hospital before to develop some, decision support tool from the system level to the, from the system, process improvement, also the individual, the disease-specific, decision tool. So when we talk about AI now, I think the data is the key, right? Without key, we cannot develop any like AI, enabled tool. So from your perspective, what you think about, now people are talking about how to get a reliable data. Or from the hospital perspective, what you think about the data can be, more reliable, that can be used to, to develop a, more accurate AI-based tool. Thanks.
Yeah, and that's one of the core challenges that we see as a system with AI, right? Because we see all these wonderful tools that can come to us and have a value statement that's real, but often, we need to have data sharing agreements where we can't let you keep that data in perpetuity. We can't let you use that data to train your AI without having some real strict guardrails around it. And so one of the things that we've seen on a few of our projects, just on the start, it's really important to be able to have a very strong level of confidence that you are de-identifying the data that you're taking and able to do that systematically without much manual intervention. That's like a core capability I think any AI company needs. Because if you get around our compliance and Office of General Counsel, willing to work with you in the first place on some of this data sharing, it's got to be de-identified, if not deleted after a certain amount of time. So that's really tricky, and I don't think that that's something that healthcare's quite caught up with industry yet, because we have a low threshold of tolerance for anyone doing anything nefarious with data, even if it's with good intent. And some of our rules and policies around that really prevent the furthering of discovery with AI and development of it.
I think, Matt, you hit the nail right on the head. We've seen many projects die before they even made it to, conception because of the data element in something called HIPAA, Health Insurance Portability and Accountability Act. And there's some reform that needs to happen, but it really makes it difficult. And I think that gets to Philip's point too. Another reason why it's not done on the clinical side too much. It's tough to share that data. And I've spent thousands of hours de-identifying data and still having problems with my legal and privacy team. So I think you said that well.
Thank you.
It could be a great opportunity, though, if you can partner with the system in like a collaboration or co-development opportunity, right? So that if you were more part of that strategic agreement, then that could be a way. But you have to think about, is that worth giving up equity? And is that worth the royalty and licensing fees that might come around with to do so? Sometimes it might be, but you want to have a strategic partner there.
So that's interesting for, say, a company like Orion. And I don't mean to pick on him, but I'm familiar with his company. He's matching a diagnosis with images. And he can de-identify them eventually once the patient has been treated. But that asset, that data becomes an asset for him, that he can now use that to train other software down the road. But what I'm hearing you saying is there's actually pressure to do away with that data for fear of, and so how does that, because all these little startups are never going to get there if they don't have access to data to train them. And once it's de-identified, I think the assumption is often, well, now we can use it. But what you're saying is you really can't. I mean, is that what I'm hearing?
That is the elephant in the room, yes. But it's also a wonderful opportunity for a company like Orion's to partner with the system. And they have more patients of diversity and skin color that would greatly increase the threshold of accuracy for his product and make it more equitable, so that there's a value statement there if you were able to partner with the system to get more of those images and work. But to your point, Philip, the system's never going to just probably give away that without some type of additional agreement layered on top.
Interesting. So as long as the data stays in the organization, it's okay. Or in your organization, not in, that's interesting.
Yeah.
Okay.
Our privacy folks always say, well, if it stays in our four walls, we feel much better about it. Can they come on site and do their work? Those tend to be the things you go through. And, you know, I've always said companies like United Healthcare who own Optum, and Optum, I think, is probably the furthest ahead in the AI world out there, but they have the data from every single claim that's submitted across the country. Sitting in their repositories, they request records, they can hold all that data as well. So I don't know, I think there's some unfair advantages out there with the clearinghouses because they do have the data.
Can I ask you a question, a data question, but in terms of using apps, because there's so many apps out there collecting all this data from burns to menstrual cycles. But when, and this is separate from privacy agreements with the institution, but when a consumer uses the app, I assume that you click on, you can use this data for blah, blah, blah. So then, sorry, Orion, you're like our test case here. So Orion owns the data and the consumers have given freely their permission. So now it's Orion's to do as he pleases, correct? From a legal perspective.
Absolutely. And with a third-party app, if you get that far where we'd recommend it, then that's fine. And we have a few digital therapeutics where that's the case. You know, we prescribe it out, they start using the app, that app's data is that app company's asset. So that's not something that we would own, but it comes up early on in the negotiation and consideration of would we even do that because of that data issue.
Yeah.
Very good point.
Also like to bring up that the way that we have structured our data agreements, we sort of go home with the patient too. So when they leave the product, they have the option to help the next patient down the line by leaving de-identified data with us, or they can choose to sort of wipe the record clean and say, okay, now I want my records expunged. So that's something that's pretty important to us, making sure that people share what they want to share and nothing more.
Well, what % expunge their data or asks to clean the slate?
I really wish that I could be in a position to tell you that, but we're still pretty early stage. So working in the pilot. So far, we have not had any real patients working on the app other than friends and family.
Test cases. Gotcha.
I would imagine most people will allow you to keep the data. I would be surprised. I think if you can get at that level, that's, an ideal state.
We're not expecting, 95% of the data to be wiped, but there are some people who have very strong privacy concerns and want to make sure that we respect that.
Phenomenal to have that as an area of focus early on. So kudos to you. Usually it's an afterthought. Just on why the data is such a a core issue. And Paul, keep me honest here with Maine, but for us, it's because so often when we get in the clinical realm, we want the source of truth to be our record. And if data is hanging out there in bulk, whether it be to train an AI or in a different app that might say something different than what the doctor prescribed, that's a risk for the system, and that contradicts what we find to be our core source of truth and what we lean back on as a system if anything were ever to come up in the court of law. So there is a reason behind it, and I think it's prudent, but still hopefully we can find a better middle ground.
Yeah, I agree with you. I mean, a lot of it comes down to legal and to physicians, because physicians, number one, don't want to be sideswiped. And the second thing is, we need tort reform in this country, in my opinion, not to be political on this, but everyone can sue for anything, and they try to protect that data as much as possible.
You're better off developing these things not being part of an institution. I mean, there's much more flexibility for Orion versus somebody who's in-house at Children's trying to do this because of the non-competes, whether we're tethered to our institutions to some extent. And then have
absolutely a trade-off.
and then have the hospital buy it afterwards. Just talking.
We do see some of our PIs at MGB, though, they come up with some phenomenal AI solutions for their clinical workflows. And because it's in-house, and this is something we can all be better on, we can clear pathways to really get things done and move faster than perhaps you would be able to outside. We have ways to get things that are pipelined for FDA clearance. We have ways to be able to get more exposure to different clinical settings. So there's definitely a balance there.
Yeah. But intellectual property, the Children's will own it.
Right. Then you give up, or you might only get a royalty out of it. So there's a trade-off.
I was going to say, we've done 2 joint ventures in the last couple of years in the revenue cycle, but we own source code, and there's an arrangement on sales to split. So yeah, you do have to give up equity if you want to be given full access. I mean, it sort of feels like Shark Tank, where it becomes a negotiation on what's going to be given up. But I've seen it on 2 projects we've done.
Thank you, Mr. Wonderful.
Yeah, no kidding. But it does become some of that. But it does move you along much, much faster.
So I'm looking at the time. We got 3 minutes left. We can open it up to questions. We can debrief on our key takeaways. Does anyone have anything pressing they'd like to discuss?
So I have just a quick comment. I view the world oftentimes as an investor, and I think investors in companies like Orion, they see the data as an asset. And I think it's an illusion if what you say is true, that they really need to rethink that. It's a misconception potentially. Just a comment.
It's an asset if you can get it. For sure. Well, I see we got 10 seconds left. This has been a pleasure. Thank you all for joining the breakout discussion, and
Thank you.
see you back in the main room. Take care.